I titled this, My Brain Won't Let Me Do That, and this has a little bit to do with this distress that I hear all the time. I think that's a wonderful word that we got from Dr. Mrazek, and we're going to hear more of it coming up. Just wanted to let you know that I am active in my community, and I do speak for Hockey Alberta on concussion and injury prevention in that environment. Also have chances to speak at various other places like libraries and talk about the things that are important to them. I have 2 publications. Yay! I am firmly in the middle, right? Not the first, not the last. I am a contributor. And so that's the space that I've carved out for myself, is I'm a contributor here. And I'm here to represent the physios. Do we still have physios in the room? Yay, okay. So I'm here to rep. We're gonna go through this. So we have 3 main objectives. We're gonna define the clinical tests that we use most often. We're going to differentiate headaches so that our doctors who are in the room and our neurologists who are in the room, all of our specialists, know where to send people. And then know where and when. And a third part there is we're also going to look at the interventions that we provide. Because I can tell you, as a physio, I have no medicine and I have no needles. So I'm not a dry needling practitioner. I am just me, which is all we need to be, okay? So we want to have different interventions, and I think that's positive. Where I'm drawing my inspiration for today is from 2 clinical practice guidelines and from the most recent consensus statement. So this is where we're going to get all of our inspiration from. And I got to say, I love clinical practice guidelines. They tell us what doesn't work so we can do other things. They give us a framework. I think they make us more creative, not the other way around. So we're going to use them. What clinical practice guidelines have done for me in my practice is forced me to take data down, put all of my clinical information into data packages, analyze it, and then be fortunate enough to present at all of these wonderful conferences. So clinics, although it's way harder, but clinics can produce information that's useful. And we can watch what we do so that we can get better at it. So this was published in abstract and in poster format at these conferences. And what I want you to see here is that the orange bar is where people with these concussion symptoms were not getting anywhere. The green bar is where we started to treat them. So not getting anywhere. They were trying really hard, right? They were in various places, in various facilities, maybe without coordination, and that's one of the things that we provide in our clinic is that interdisciplinary space. But the key point there is if we measure stuff, the knowledge translation bit works, right? Okay, if we start to look at what we do, we learn what we do well, and we can throw away what we don't do well. And so I highlighted the worst of the worst, the most chronic, and then the acutes. And so early access is something, and this is a point that was brought up at the consensus in Amsterdam. Early access to care makes a really big difference. When we get involved at a later stage, I want you to know there's still progress to be made. There are still improvements to be had. Some of those improvements are, we measured cognitive, we used a proxy for cognitive by the return to work and learn. And there's a huge improvement in people's return to that aspect of their life. On the other side of it, the physical side, there's an incredible return to physicality. So 68% went back to the same level of sport, but 99% moved out of, do you know in the concussion world, do you know the word rest? Rest until we get better? Everybody moved out of the rest phase. We don't want to rest to get better with concussion. Concussion needs to be a very active recovery. We need to be engaged in our recovery. So these are the things that I hear all the time, and this is what Dr. Mrazek was talking about the distress that people feel. And I spend time with people, and people are so creative with their words, and the more creative they are with their words, the more stressed I know they are about where they are. So, and this is a statement that I hear all the time, and I'm sure that our other concussion docs, Dr. Diebert, would hear this too. This is, and you actually mentioned it in your presentation, where the phenotype of the concussion has changed, the nature of the concussion has changed, and it's changed because of the injury. This is not my normal headache, this is a concussion headache. And what did we learn from Dr. Diebert about concussion headaches? And this is what I tell my patients, they don't exist. In the classification system, there is no such thing as a concussion headache. There's a post-traumatic headache, meaning you've been hurt, right? And then what do we do with that knowledge? We have to listen to what it sounds like, what it feels like, and categorize it from there. And so that's what our docs are doing, is trying to kind of put it into some sort of sense. The two most common types are the migraine and the tension, and then the third added on there by the international classification is this medication overuse headache. But I want you to think also about these neck-related headaches, because they're a real thing too. They're just, I don't think we have as much, well, we have some research on them, but it can be difficult, but you have to be open-minded. And I want to add that mixed subtype. So sometimes these headaches are layered, and if we recognize one piece of it, we can treat that one piece of it and see what other pieces fall away or see what else becomes obvious. So thankfully, I don't have to go through those classifications. If you want more detail, go to the international classification. It's all there for you. When I'm doing a headache assessment, I start with the history, and I ask lots of questions, and I make sure I get answers. One of my most favorite questions is, are you using over-the-counter medications? And almost always they say yes, but only when I need it. And when I hear only when I need it, I stop and say, wow, how often do you need it? Because that's how we get into that medication overuse space. And I do that because I have an hour-long assessment. I do that and I write it down and I send a letter to the family doctor and I send a letter to any specialist doctors. I might be the only one that was able to elicit it, right? And so we want to be eliciting, as physios, we can elicit this information because we have time to talk to people. And I know our specialists are trying their hardest to elicit it too, but it's not always that easy. They're embarrassed by it. They don't want to tell you, right? They don't want to tell you that it's every day or that it's more than once a day. So we want to get into that. I ask about medications because I want to support what the family physicians and what the specialist physicians are prescribing. I ask, this is my fun one for my patients these days, is I get to say, substances and supplements is the point in time where you can tell me about your cannabis and your vitamins in the same sentence. And that usually relaxes them into telling me the truth, which is lovely. And then because this is, the headache assessment for me is always a part of my overarching big concussion assessment. I've steered away from that part today just to talk about the headaches. So just know that these other aspects are equally important for me. Headache, dizziness, neck pain, and sleep are my 4 top ones that I dig to get the information. And then what I do with it, and interesting because although we're talking about a headache assessment, what I do with it is assess a neck. So I do a neck assessment. And the reason I do that is because that's what our neck guidelines say to do. We need to understand the pain that's there because a lot of times it can be coming from the neck. So in this clinical practice guideline, it was level 1 evidence for these 3 categories, for these 3 tests. So we want range of motion, and we get our level 1 evidence if we're using our goniometers or another measure, whatever, you can use your phone, inclinometers, whatever they want to call. But we need our goniometer. We want to palpate. So we want to get our joint dysfunction going on here, and we also want to palpate for tenderness. We want to palpate our muscle structures, and we're going to ask, where do we feel it, right? So what I tell my patients, a lot of what you're going to hear today is how I explain things to patients too, but I have maps in my head of where joints hurt and where muscles hurt, and most of the people in this room have maps in their head too. If I touch this and it hurts over there, then that tells me something, right? And we want to palpate that nerve, and if we haven't palpated nerves before, I think we need to do that. And then this cervical flexion rotation test has great specificity and sensitivity, especially if it's paired with that tenderness. And then we know we're dealing with pain that may be coming from these neck-related structures, is how I describe it to people. Okay, so we're going to use that flexion rotation test. And we saw a picture of it earlier, right? But the key to this test is to get maximal flexion. You need to lock out your lower segments so that you are rotating purely at C1, C2, or as much as possible, as much as humanly possible. So this is another test that I like to do regularly in the clinic. This one is called the flexor endurance test. This one has level 4 evidence. There's a lot of different tests that are available. The evidence behind them still needs work, but I think it's useful, especially if you get really, really used to your favorite test, then you begin to see a lot more in the test, and we can share. So this is, do you all know the flexor endurance test? Okay, so what we're doing here is this person is going to be lifting his head 2 fingers off the table, and he has to hold the double chins, and it's being timed. So what this test tells me is it's a relationship. It's a relationship between using your muscles and having pain onset. And I tell people they can stop, they must stop if they feel pain. The first time they go through this in the assessment, I say you must stop if you feel pain, and or I might ask you to stop if you lose your position. So we can cue once with this test, and if they lose the position, it's done. If they have pain, it's done. And then my next question is, where is the pain? Of course, right? Is it in the neck? Is it in the head? Is it a combination? But that test takes 45 seconds to do, so it's actually kind of efficient. The other flexion rotation test I find is more cumbersome, and I use it more to prescribe exercise. I don't use it as my initial, do I have a relationship between the neck pain and the headache? The evidenced treatments in this concussion space come from our concussion consensus group, and I've put some time frames on in there, and we'll talk a little bit more about those time frames, what types of therapies are applicable at different time frames. Exertion therapy, I want you to know this is new. The consensus was published in June of 2023, so this is really, really new. We're getting more into active recovery. There is reason to stay active and not to, and rest is this soft period, 24 to 48 hours, as needed, but activity is allowed, especially if it isn't hurting a person, right? It's not causing pain, and there's even some push into that 24 hours to do things like walking and reading and in order to be active in the recovery. On the cognitive side, there is evidence that was reported at in the consensus statement that says we should be limiting technology for the first 48. But after that time, we need to be starting to bring it back. Interesting, because our neck and vestibular-related physio is meant to start 10 days post-injury, and I think there's reasons for this. We'll go through some of those. And then psychology is another therapy that is evidenced in this field, in this area. In the acute concussion, and I put with headache because this is a headache presentation, we're going to start some physical activity as tolerated in the first 48 hours. So this is the treatment part of our objectives. Walking, stationary cycling. really, we can let people be a little bit creative to do things as long as they're safe to do. So no contact or collision or falls expected. So very, very competent activities engaged in. The clinical practice guideline on concussion gave a very clear mandate. They used very strong words, which I love. They said, you must educate, and this is given a level A for evidence. And the things that they're asking us to educate our patients on is normalizing their symptom experience. The distress has some validity in that early time frame. We need to normalize what they're experiencing. We need to also talk to them about the nature of the different impairments that occur with concussion. Concussion is a brain injury, and some of the docs that I work with, I've talked at length about the neck, and my favorite neurologists in the city will say, yes, Codi, but the neck is not the brain. And I know it's not the brain, but we have overlapping symptoms, and we may have more than one injury at the same time. And what's lovely in the new consensus is we're talking about concurrent injuries now. We're talking about an injury to the brain plus a neck plus an inner ear motion sensor system plus, right? So we're acknowledging that these things are not so narrow. And we have to, because the symptoms are so complex. And if we can work on one layer, we can make it more clear for another practitioner. Okay? So subacute concussions is this 2 to 10 day phase, and really the mandate with this headache that's happening in this space, even if we are starting to understand that it might be migraine, it might be tension, it might be neck related, what we're going to do with that headache is we're going to start to exercise that individual, and we're going to do it very carefully. Right? There are tests to be careful. We're going to find their heart rate by going through a Buffalo concussion test. And then we're going to set their activity at their exercise threshold. And guided is better. So you can ask your individuals, your patients, to go for a walk. But if they actually have an idea of what they're supposed to feel like when they're doing it, how intense it's supposed to be, should I be sweating, should I be breathless? Going through it, and we stand right beside our individuals when we're doing this test. We use the information we gather to teach them what their body should feel like. And when we do things like that, we get a lot more compliance with their prescriptions, with their exercise prescriptions, okay? We use a pain scale. So again, new, June 2023, new guidelines for how it should feel while you're doing the test. While you're doing the test, wherever you start your test, whether it's a 2 or a 4, that individual must stop the test if they rise by 2 points. And then what's going to happen is we're going to monitor how long it takes for their symptoms to come back down to wherever it was. So if they were at a 4 and they got to a 6, that's a mandatory stop. What I tell our patients in our clinic is that's your mandatory stop, but you are allowed to stop for any symptom at any time. You don't have to get your full 2 points up. Okay, we want to stop them before they get too far. And then we use that information to guide. So what do we do when we get to the 10 days? The 10 days is when we start our cervicovestibular rehab. So imagine a physiotherapist, a hands-on being, right, likes to touch people, and we're not touching people for 10 days, right? There's a reason for this, and the reason for this is that there's a lot going on in the brain in that initial 10 days, and we are there to document some spontaneous recovery of some systems. And imagine if we don't touch people, imagine that a certain percentage of those individuals, their neck pains are going to go away. All by themselves. That's what I call spontaneous recovery, and I think that's magical when it happens, and I want us to get excited about it when it happens, okay? If it doesn't happen, that's when we get involved in our manual therapies. That's when we get involved in our specific exercises. And I've used words here, but we use words, physio words, in a different way sometimes than our physicians do. And we use words neuromotor and sensory motor. And what we're talking about really is how muscles work together and we're talking about how they feel and what their little proprioceptions are, not the big gross proprioception, just small things. But these things make a really big difference in the pain presentation, and that's why I want us to talk about them. I've got a little video coming up that shows some of the exercises that can be done. I have a little warning here for you though. Oh, there it is. So I have a little warning here, and I'm taking a little bit of fun from Jackie Chan. When we're engaging in our therapies, we need to not cause more pain or increase the full pain burden. And so here's our little word of caution. And this comes out of a systematic review that was done fairly recently in 2022. This one had to do with those neck-related headaches, the cervicogenic headaches. When the outcome measure of pain was being monitored in this systematic review meta-analysis, manipulations were not superior to no treatment. Okay? Pain frequency, if that was, so the frequency of the headache, manipulations are not superior to no treatment. Okay? If our patients are getting into that central sensitization space, which is what's happening when we have these persisting concussions post-injury, then they're not really great candidates for any manual therapies. And when I showed you that big orange section, the individuals, I asked them which therapies they've been receiving because I know that I can't repeat those ones. I have to be more creative and I have to come up with something different. But there's a lot of manual therapy in that orange bar. So if you're finding your patients are continuing with their pain, we have to change the way we do our techniques and the way we do our exercise instead of the manual. So manual's not our only one, but it is, and you all know, there are those wonderful, profound times where you touch somebody and everything melts away, right? And I'm not talking about that, but I'm talking about those times when you're a little frustrated because their pain goes away for an hour or two, maybe like the nerve block, and then it comes back, right? So we want to be a little bit cautious in that area. And whenever we have somebody's had a nerve block, or I might make a referral to a neurologist for a nerve block and we get that positive diagnostic, I get so excited because I know I have a job, okay? I know I've got work to do tomorrow, and I get really, really excited about that. So what we're going to start to do once we're past the 30-day mark is we're going to rely on our active rehab. And we're going to do our cervicovestibular, maybe with some manual, maybe not, but we're going to be really cautious and we're going to really monitor our patient's response to the treatment. Okay, so these are some of the ways that we do these neuromotor and sensory motor pieces. And here we're combining some cognitive with some impact, with some vestibular. We're going to see a different view of this. So is this a neck exercise? Is this a vestibular exercise? Like, what are we doing here, right? I love it because it's combined targets. The neck has to be not painful to start bouncing, right?
Purple, triangle, purple, triangle.
So we're combining a lot here.
Orange.
And the other thing, I guess, that I do intentionally with this is I love the games, because patients love the games. And if we can get it into some sort of fun space, what happens is we're decreasing the stress and distress. And then the pain can come down again. This one I call back to play. Okay? Because my kids just shake their heads. So something that's kind of nerdy and fun that I like to do is I like to look at these systematic reviews and I like to see what the sham was, just because if they're seeing the sham treatment, right? I want to know. Do you guys want to know what the sham treatment is? Because people pick sham because they think it has no effect. Sometimes they pick it well, sometimes they don't, right? But I always want to know. So the sham in the cervicogenic is no treatment. Laser therapy was chosen as a sham. So question yourself if you're using modalities or electrophysical modalities, which ones work and which ones don't. Non-specific fitness, but remember this was a cervicogenic headache group, this wasn't a concussion headache group. So this concussion cervicogenic, our cardiovascular activity is mandatory, it's wonderful and it's great. And in the tension headache, stretching. Interesting, because how many times do we prescribe stretching and expect a result or expect a change? I think we need to question our strategies, and I think we need activation of muscle, not necessarily stretching. And when do we refer to physio? So big picture, when I think of what I do every day, I think of myself as a rehab professional. And to me, rehab is helping people recover what they've lost, right? Find a new way to do, or do more with what you have, right? So if those are things your patients, the docs in the room, are struggling with, physiotherapists are key to your recovery plan for your patients. And we are going to support your medical management, but we're going to work in a different way that is complementary. So technically speaking, physios are great with cervicogenic headache and tension headache. Migraine is a tougher beast, but I do find that if there are triggers to and from, then we can help. And definitely if there are other concussion factors involved, other of these coexisting injuries. And really, if your patients need to regain fitness or work functions, this is where physios live and breathe. And if there's a need to utilize these lifestyle aspects for managing ongoing pain, we might call it managing headaches, or we might call it coping. I know I spend a great deal of time educating and walking through coping strategies. I don't know how much time we had. I had a couple extra slides at the end if we wanted to go through how we can work on that lifestyle education and to support our physicians, because our physicians are working really hard and we need to support what they're doing. Okay? Pardon? Okay, I'm gonna go, so I'll go back to that one. We won't do this, it's too late. Okay, lifestyle. To me, headaches, particularly migraines, but headaches in general are a big, gigantic game of Tetris. If you can pair things together, lifestyle factors together, you can keep your stack low and you can keep your headaches from happening. But if that chaos of distress comes in and everything's piling up, it's game over. So what are lifestyle factors? We have food and water, right? If you're stressed, what happens to your meal plan? And do you miss your intake of water in a day? Sleep, right? How does stress impact sleep, right? Basically, what I say to patients every day is headaches thrive on chaos. They live and breathe by chaos. So if we can take some chaos away, if we can make some plans, if we can become persistent with exercise, because exercise is a preventative for headache. We heard a lot of the medical, this session anyway, was a lot of the medical around the acute. But if we're getting in, and rescue medications and rescue strategies, but if we're getting into these chronic situations, we really have to talk prevention. And exercise is one of our preventatives. So if we can pair exercise and not let stress take our exercise away, if we can make sure we're eating and drinking, if we can maximize sleep, then we have a chance to start to say, okay, I'm stressed today, I have to do my exercise today, right? This is not the day to give that up, because I need to pair that with my stress so that I can keep my stack low and stay far away from headache. So this is one of the visuals I use with my patients. Thank you, Dr. Becker, for letting me add that one in. And I don't have, and then lifestyle, you know, this is BDNF in a nutshell. Okay.